Okay, so the meeting is being recorded for minuting purposes and for future reference. This is a meeting in public of the 6 Staffordshire CCGs. It is our final meeting in public, and so welcome to, we have a couple of people from the public here. Welcome this afternoon. There will, as ever, be a time for questions towards the end of the agenda, and would like to take questions at the end rather than during the proceedings. Can I also ask governing body members to to decline from using the chat function to ask or answer questions, because that's not visible for public record. As far as possible, ask that through myself. Jill, what apologies do we have?
I have received apologies from Craig Porter and Mukesh Singh. Okay,
and I believe Sally Young is going to be a little late as she has some training, and she'll join us shortly. Any declarations of interest that other than what's on the register or specific to any agenda items this afternoon? Got a hand up. Sorry, Paul.
Sorry, Chair. Paul Gallagher, lay member for Cannock Chase PPG. Chair, it was back to the last one for apologies, and Heckles sent her apologies as well, please, to be recorded.
Okay, I'll add that to the record. Thank you, Paul. So there's no declarations of interest. Paul, Coracy.
Thanks, Paddy. Paul Winter, Deputy Director of Corporate Governance, Compliance and Data Protection. Confirmed that all CCGs are core.
Excellent, thank you. And that brings us to the minutes of the last meeting, which is the meeting of Thursday, the 31st of March. Just going to walk through the minutes. If there are any corrections or amendments or actions that haven't been picked up in the action register, can people let me know. I won't walk through every page of it. I'll just say globally, are there any corrections or items to bring up from the minutes of the last meeting? Jan.
Page 9, which is 15 of the bundle, at the bottom, it starts with PD stated. On the third sentence, it says PB asked if they were anticipated they would get some growth, otherwise the strategy was not going to deliver. Should that be PD?
And you were thinking of Peter rather than?
Yeah, rather than Paul.
Yeah. So there's a question. I don't know if Peter or Paul could enlighten us on their interpretation of that.
Paul responds with regard to the formula.
Well, Peter, we're going to attribute it to you, I think. Does that sound plausible?
Yeah, I think it was all linked up in terms of you know, how the strategy was going to work. So yeah, I think I did recall, or do recall, mentioning growth. So okay. So I'll claim it, Paddy.
Okay, we'll amend the we'll amend the minutes accordingly. Thank you for taking that one. Any other corrections on the minutes? Are we happy that the minutes are approved? Silence is assent. Okay, we'll take the minutes as approved. Action list. There are no actions on the action list, so we'll move on to item 7, which is the corporate risk register. Paul.
Thanks again. I'll take the paper as read, but just to assure the governing bodies, the usual full update has happened again this month. There are a couple of changes to note. One, risk has increased in score. 1069 around waiting times has gone up to a 20, and 2 scores have reduced slightly. 983 and S600 down that's reduced down to 12 in relation to medically fit for discharge and transforming care partnership risks. Otherwise, no other risks have been closed, no new ones added since we last discussed the risk register at the April confidential meeting. So over to members for any questions.
Any questions for Paul on the risk register? John.
Thank you, Paddy, and indeed Paul. John Howard, lay member for Stoke-on-Trent CCG. It's the one that's currently at 20, Paul, and looking for perhaps other colleagues to support you in the response. But we're very near to handing over to our responsibilities to the ICB. I just wondered, at system level, how the approach to dealing with waiting times is being handled. Are there some special meetings, some escalations taking place? What approach is happening at a system level?
Okay,
Paul,
thanks.
well,
I can start on. I can start just on the process. So, as at the 30th of June, when the CCGs are abolished, the open risks on the CCG's risk register will transfer to the ICB's risk register. So, at midnight on the 1st of July, it has a live and functioning risk register with the inherited risks, for want of a better phrase. So it stays on at the score as it hands over in terms of the process, and then going forward there'll be a new ICB risk management strategy, system, policy, process, etc., including working with partners to capture the genuinely system risks, which is the new dynamic to reflect the new way of collaborative working. As far as to the actual process, the kind of operational discussion meetings, as the strategy forming meetings, I'll probably hand over to Paul and Cheryl for their take on the F&P roles and the other committees that have been agreed as part of the ICB's governance structure. But there will be a handover, but I'll be over to Paul because he'll be able to talk to you about the system oversight framework.
Paul, do you want to take that first?
Yes, sure. Thanks, Paddy. Thanks, Paul. Yes, so Paul Brown, CFO. As Paul mentioned, we have a system strategy finance performance committee that is overseeing all of this. I'll talk about it a bit later on, but we're developing a system plan, John, an operating plan, which will define all of the objectives for the system, and obviously within that, very clearly marked our improvements to waiting times, as you mentioned, which is a key part of what we're trying to do in this current year. We have a plan at the moment which does show that we will eliminate all long waiters beyond 104 weeks to 2 years, and we'll do that by the end of June. And then there are improvements thereafter to start bringing the waiting list down further. And we're looking to get down to no patient waiting more than 78 weeks by the end of March 23. We haven't quite got the plans in place to get down to that level yet, but we're getting there, and it's a system effort to do that across all of our providers. So hopefully that addresses your point, John.
Yes, thank you. Yeah.
Cheryl, do you want to add to that?
Not unless John wants me to say something specific. I think the bit for me, really though, John, is about the quality and safety aspects of the waiting list, and I think particularly that's why Heather and others are really focused around this risk, the 1069. But actually we're working together as an MDT to manage this through the council board, as well as the planned care board, and some of that more, not lower level as such, but that very detailed operational approach to individual pathways.
Yeah, the most important dimension, quality and patient experience and their safety. So thanks for adding that. Yeah.
Okay. Anything further for Paul? Any more questions? Okay. Thank you, Paul. I think you're staying on in Sally's absence to do the board assurance framework, I hope.
Indeed, yes. Thank you. So in a similar vein, the BAF has had its recent monthly update as well. We're in the kind of the 3 month sort of rollover period, as it were. So rather than create a new BAF we carried over the objectives for the 21-22 financial year, and we are showing a generally pretty good position in terms of overall assurance. I mean, obviously there are still a number of risks, our current score, which aren't at their target score, but I wouldn't associate that necessarily with delivery of the wider objective. We've got a good series of controls and assurances in place across the whole of last financial year and for this 3-month period until the transition completes. So whilst some are showing no change in score and status being equal or a couple being reduced, you know, all of the usual the customary sort of controls and assurances processes are in place to support the wider sort of achievement of those objectives. So I think as a end of school report, it's in a goodish place, about as good as could be expected. But again, over to anyone for any specific questions.
Any questions for Paul on the board assurance framework? John?
Yeah, me again, sorry. It was taken at audit committee, and I think it's important we have the same update at public board. It's 994, the one that's risk rated 20, the risk that we might be losing, you know, or are losing good staff at a time when we can least afford to do so. But there was some good news given to audit committee in terms of the turnover level that reduced from 4% to 1.2 or 1.4. I think if someone can come in and confirm that, I think that would be good for the minutes, Paddy.
Okay. Can somebody confirm the turnover figure?
I think it was 1.4, wasn't it, as we discussed at the, but I mean, either way, that's a significant reduction on 4%, which is pretty high.
Yeah, which someone reduces the risk.
Yeah, I mean, if it's okay, Paddy, just to yeah, we obviously did have this this discussion at Extraordinary Audit Committee, and I guess just to provide the governing body with assurance, Peter Axon and I are working very closely together on ensuring that we have a smooth transition. There is the continued employment commitment to all staff from the 1st of July. But probably going the extra mile really in terms of particularly meeting with staff who sit within the directorates for whom a director hasn't yet been appointed. So those staff moving into, for instance, Paul Brown's finance director's team, there's some certainty there. That's the boss. I know what my job's going to be, and they're probably more assured. I think people who's haven't yet got a director and whose current director's leaving, and there'll be staff, for instance, in Jane Moore's strategy planning performance team. There isn't a directorate, the same directorate in the ICB, so teams and individuals will be going to different places. For those going to places where there's no director in place, Peter and I again have been meeting with the individuals affected, providing that assurance, trying to give them some certainty around where they will be on the 1st of July. And you know, a degree of turnover in organisations is a healthy thing, particularly if it's for career development, because not everyone can stay here and progress their career in 6 relatively small organisations that they want to, so that's good. But yeah, we want to be careful that we aren't losing people because we're not able to provide the assurances around their futures that they're looking for. So it's an absolute priority for me and for Peter, John, and something we're working very, very closely with staff on.
Thank you, Marcus.
Okay. Any further questions for Paul on the board assurance framework? Okay. Down as approval, but I think it's just a received report. I don't think we need to approve the BAF. So that takes us on to the chair's report, which I'll talk to on behalf of the 6 chairs. I'll pick out some of the themes from the report, but I'll keep it fairly brief, I think. As we'll hear in other reports this afternoon, some of the pressures in the system have somewhat declined over recent weeks, but there are still significant concerns around pressures in urgent care with the ambulance waiting times, and with the elective recovery that we've just highlighted in the risk register and the BAF. Everybody's working very hard in sort of move to transition into the ICS, and everything is I think coming together for the 1st of July. In primary care, just wanted to pick up the closure of the Hanley Primary Care Access Hub, which is known as the Hanley Walk-in Centre. This has been discussed at previous meetings, and there's been a significant process of engagement around this decision. We were anticipating closure at the end of July, but recently found out that the leased building is going to be sold to in public auction at the end of June. So the vacation date has been brought forward. We are assuring everybody that the services that were delivered from the walk-in centre will be adequately picked up within the system, and that the finance will be recycled into primary care projects in the north. COVID vaccination, the rate levels of vaccination are currently down to circa 4,500 doses a week, somewhat less than the 120,000 a week that we touched on in the early part of the programme. Predominantly around the continued spring booster programme, children's vaccination, immunosuppressed, and the evergreen offer for people who have to be vaccinated. The programme will go into a sort of quieter phase through the summer when the spring booster campaign comes to an end. We will continue throughout that time to give the evergreen vaccination offer, but we don't need the current 40 sites, and we've asked a number of sites to stand down, so there'll be 17 sites running through the summer. We are planning and anticipating a autumn booster campaign that will coincide with the traditional flu programme. JVCI gave some details of this, but we are planning a number of scenarios around that campaign, and we anticipate that most of those sites will stand back up to deliver that, along with our general practice and community pharmacy. The clinical and professional leadership programme for the ICS continues to be developed, led by Rachel Gallio and a multi-professional working group. There's been some changes in response to a really wide programme of engagement around the model. There's been an alignment of roles leading back to our recently appointed Chief Medical Officer for the ICS, and also a sort of some rethinking of the place-based alignment of clinical professional leadership as the local discussions around how place will align to the higher tier local authorities is worked through. The clinical professional leadership model was taken to the Shadow Integrated Care Board last week and was well received. And as we transition into ICS, the jobs within that will go out to advertisement and appointment. And the budget that currently is used within the CCG for clinical and professional leadership will be used to fund the new model. Again, one of the moves within the whole change in structure is to broaden the leadership and take a multi-professional approach to clinical leadership. The Health and Care Senate met on the 12th of May, discussed a number of issues, probably picked up in some of the other themes this afternoon. Particularly, there was a discussion around planned care and the current 104-week waiting times, concerns around staff, particularly around diagnostics, and there was some resolve within the Senate to focus on this and to help support the ICS in solutions for the elective backlog. Further discussion around ambulance service and the concerns falling out of delays and the risks to patients. And finally, discussion around FIT testing. FIT testing is a diagnostic test which is currently used in the bowel cancer screening program, but is going to be integrated into the colorectal cancer pathway, and we're having quite prolonged discussions around how we best do that in the county. That's all I probably wanted to bring out of the report. Happy to take any questions. No questions. We will move on to the Accountable Officers report. Marcus.
Thank you, Chair. I'll take the paper as read, but there are a few things I did want to just pick out from the paper. I think the first one, just a huge thank you to Paul and his team, Paul Brown, our Chief Finance Officer, and his team. So as you'll see in the report, we have broken even for the second year in a row with a small surplus of about £11 million. So all 6 CCGs collectively and the individual CCGs have broken even. Now, I do appreciate the last 2 years we've had the benefit of COVID monies to enable us to cover off some of the costs of our COVID pressures. But even allowing for that, we still had a significant gap between income and expenditure, which Paul has worked very closely with system finance directors to close off. So the fact we've ended the year with, for the second time in a row, with a surplus, an in-year surplus, is a huge achievement. Whilst we still have a significant underlying deficit, that was around about £200 million. When we came into the pandemic, that's now down to about £130 odd million, of which the CCG's chunk of that is the biggest chunk, but it is moving in the right direction. We do have a financial plan that's been submitted, which does get us back to where we need to be by, I think it's 25-26. There is still a deficit in there of 28.6 billion, as you'll see from the report, of which around about just over 20 billion sits for the CCGs. Quite a lot of discussion at Finance Performance Committee around that. That plan hasn't yet been agreed because there is a deficit. But by way of assurance to governing bodies, that is the smallest gap between break-even to break-even that any system in the Midlands has got. And I think Paul tells me one of the lowest gaps to break-even that any system's been able to submit across the country, and there are 42 ICSs, something like that. So whilst there is still a deficit there that will be pushed to close, it's a position that the whole system has agreed, which is probably, if not the first time, that hasn't happened often. So we have very much approached this as a system under Paul's leadership, and submitted a plan we're confident we can deliver. Probably still some push from the centre to get that closer to zero, but probably a better position than we've been in for a number of years. So thank you for that. Vaccination programme, just wanted to pull out the fact that we are the only system in the Midlands of 11 that are actually above average for vaccinations for all of our patient cohorts. So again, a really good place to be. Thank you to everyone who's been involved in delivering the programme, for Lynn Miller for her leadership of the programme, and for her whole team, Mel Marn in particular, but also to all of our GP practices working through primary care networks, and to our pharmacists and our providers for the work they've done in terms of getting jabs in people's arms. Let's make no mistake, the reason we're coming out of this pandemic the way we are at the moment is largely down to the efforts of our vaccinators. So thank you to everyone involved in that piece of work. It's a huge achievement. System pressures, I guess some good news to report tentatively, and this will be picked up in some of our later reports, but it does feel like we're in a better position now than we were over the Easter period in terms of our urgent emergency care. Really good update this morning at our Chief Execs Forum around the work that's been done over the last couple of weeks around resetting the system, which has delivered some really tangible benefits that we need to maintain. So in terms of the front door flow through the hospitals and discharge, in a much better position. And that's also had an impact on our ambulance turnaround times and wait times for people in the community who've rung 999. That has improved significantly, and again, some of our later reports will go into a bit more detail on that. So we were probably one of the systems singled out as having some of the worst ambulance turnaround times, particularly at the University Hospital North Midlands. That has improved hugely. So thank you to all system partners in our acute trusts, in the community, and our local authorities for the efforts they've put in to actually turn that position around. So in a much better position, and we can go through that in more detail in the later reports. Just also wanted to note on there Shrewd, which is I can't remember what it stands for now, but it's a single source of data, a single truth, I guess you could say, in terms of how our system is performing against a series of key metrics. It's available via app, many system colleagues, particularly operational colleagues, do look at that on a very regular basis. It gives us a intelligence that perhaps we haven't had previously, at least not in one place, and been able to have a look at where we are at the moment, what the next few hours looks like for operational colleagues has been a huge boon. So again, another example of using digital technology to actually improve outcomes for our patients and the wider system. ICS update, I won't go through the detail that's in there. You will have had a chance to read that. I did again want to just flag, it's not in the report. We made our submission on Friday to NHS regional colleagues. This is our submission basically in preparation for becoming an ICS on the 1st of July. I think there was something like 21 megabytes of information that we had to submit. The readiness to operate statement and a whole raft of supporting documentation, like for instance the NHS Constitution. So Sally Young, our Exec Director of Governance, Corporate Services and Comms, has led that process for us as the SRO. Kirsten Owen, Paul Winter, Nikki Harkness has been and Alison Bradley, Chair for North Staff CCG, who's been part of the group pulling that together. It's been a system effort. Everyone across the whole of our system has contributed, but it had to be pulled together into one place by a small team of people, and they've done that job tremendously well. So thank you for that. My understanding from Sally, and I hope not stealing her thunder, but the feedback we've had from regional colleagues is it was sort of a Premier League submission. So really, really well done, and hopefully it will provide the level of assurance they're looking for, and we won't get too much feedback in terms of additional stuff that we need to do. System operating plan. Oh, sorry. Now, I just also wanted to say in terms of the ICS update, part of that was the CCG due diligence work. So I am required to close the CCGs down as the accountable officer and to write to Peter Axon, the interim ICB Chief Exec Designate, that things are shipshape and we can hand it over to him on the 1st of July in good shape. Also, huge thank you to everyone who's contributed towards that process. It's been a pretty mammoth undertaking. And again, Sally, Kirsten, Paul Winter for the work they've done on that. But also a thank you to John Howard, who's chaired the Extraordinary Audit Committee, that's actually been able to provide assurance to governing bodies that the work that we've undertaken gets us to the place we need to be for the 1st of July. So thank you to John, to all of the audit committee members, and also our internal audit and external audit colleagues. It's been I think a good joint effort on all of our behalves, and probably the letter I'll be writing to Peter next week is one of the easier letters I've written. So thank you for everyone involved in the CCG due diligence work, don't know where I'm at. Yeah, and yet more thanks to everyone involved in the system operating plan, another mammoth undertaking, which went in recently, and again we've had some really good feedback on that. Probably some areas they will want to come back to us on, but Jane Moore's led that process, our Exec Director of Strategy, Planning, Performance. Again, it's been a collective effort, a team effort. I just wanted to note the fact that we've done that as a system. Jane's been able to, working with fellow directors of strategy, get everyone in a place where we've had a really slick process for putting that information together, populating the submission. And again, that's something that's very much been noted on by regional colleagues. For those of you who are around when the infamous KPMG report, which people still refer back to, that talked about very dysfunctional relationships across the system, the fact that we've been able to get our act together, submit a joined up, agreed by the system operating plan is a huge boon, I think, and probably a very positive message in terms of how we're going to work together as an integrated care system from the 1st of July. So thanks for that. And I think just also, this is my last accountable officer report. So this is our last, I think it's our last public governing body meeting before the 1st of July. We have our final governing body meeting in June, but that's a confidential meeting. So I just wanted to say thank you to all of my governing body colleagues, the 6 chairs who've sort of provided huge support over the last 4.5 years that we've been in existence as 6 CCGs with 1 accountable officer and 1 executive team. To all of my governing body colleagues over the last 4.5 years, to all of the people behind the scenes who make these meetings work effectively, and over the last 2 years running governing body meetings remotely through Teams has been a challenge, I think, for all of us. So thank you for everyone behind the scenes, and I know Jill Hackett sort of pulls the papers together and it's not always easy, Jill. I know if you get papers at the last minute and you're constantly chasing for outstanding papers. But thank you for everything you've done in terms of pulling the board papers together and ensuring they get out in reasonable time for people to read our small rainforest of papers that now come out electronically. And also thank you to our members of the public who've sort of turned up to meetings, have listened to what we said, provided challenge, but we really do appreciate you having made the time. And probably over the last couple of years, whilst we've been doing the shoot teams, you haven't actually get in your car and drive all over Staffordshire. And maybe if we could single one person out, which is Ian Syme. Ian, who's been a constant throughout my time in this system. You know, thanks, Ian. You do turn up to all the meetings. You ask some really good questions and provide the appropriate challenge. But thank you for taking this journey with us. So we've had our challenges in the past. I think we leave sort of the system in a reasonably good place. I think we've had some real successes as CCGs. Still some challenges there, but I think our financial position's moving in the right direction. I think areas like mental health I think are better now than they were when we picked up some of those issues. And whilst we are making improvements in a range of the constitutional standards, we do have some way to go, but it does feel as if we've turned the corner and things are moving in the right direction. And I guess finally, we've had a really, really difficult 2 years, probably the most difficult 2 years in any of our NHS careers. And the fact we've come through that in good shape is testament to all of your efforts and our membership's efforts and those of the wider system. So probably just a few words by way of thank you for what will be my last, hopefully, accountable officer's report. I'll have to say it again next month. So thank you, Chair.
Thanks, Marcus. Great report. We've got some questions, starting with Jan.
Hi, Marcus. I'm referring back to COVID vaccinations. Do we know how many children have now received a vaccination and whether there's a predominance anywhere in the county? And are parents readily bringing their children forward for vaccination?
Lynn,
so
do you want to take that?
Paddy and Lynn? Yeah, sorry,
Yeah.
Ben.
I'm going to ask Lynn to take that.
Hi, Jan. Yeah, that's a good question. We're seeing around 1,000 patients, 5 to 11-year-olds per week. We have got some good uptake rates for first vaccinations for the senior school children. If you just bear with me, I can get the exact figures. And if you want to answer the next question, I'll be able to report back in about 2 minutes. Is that okay?
Okay, we'll go to Tim and then we'll come back to Jan.
Okay, thanks, Paddy. Tim Bevington, Labour, Stoke-on-Trent, CCG. Thanks, Marcus, for giving us that update, and I think public in particular will be pleased to hear about the tentative good news, particularly around the ambulance handover times. I just wanted to look ahead a bit and really sort of focus on the constitutional targets. When I joined the CCG, that was still a headline concern and an issue, and as the CCGs approach their end of life, it feels as though it's still a significant issue. I was just wondering if you could give a brief commentary on what the perspective is amongst the senior leaders locally in the health economy in terms of the opportunities or the challenges and the chances of actually addressing those, particularly obviously the waiting times.
Yeah, no, it's a good question, Tim, and I was, I guess, careful in my language earlier. It's an improving position, but we've got a long way to go. If you looked at when we came into the pandemic, something I was really proud of was the fact that we had no patients anywhere, Staffordshire and Stoke-on-Trent patients on a waiting list, waiting for more than a year, let alone 2 years. And the fact we had hundreds of patients waiting more than 2 years was not the place that anyone wanted to be. So again, all of our providers are making significant strides in terms of reducing the number of 2-year waits, and that will be at 0 by the end of June. That's the target we've set, and that's the target we're committing to deliver. We've got a lot of work on our hands, though, in terms of the number over 52-week waits, and that's going to take some time to work through, because obviously new patients are coming on waiting lists, and some of that will be unmet demand that's built during the pandemic that now needs to be seen, plus all the patients that are on the waiting list. So it'll be a delicate balancing act for all of our providers in terms of meeting demand as it comes through the door, as well as reducing the number of long waiters. not a place where any of us wanted to be. And I think the last 2 years, whilst there have been some positives in terms of how we work together as a system, something that we should all be absolutely prioritising, which we are, is bringing down those waiting lists so that people get the time, the treatment that they need in a much more timely fashion. Let's not forget the NHS Constitution. Again, it's a legally binding document, and it does set out constitutional standards that all of our patients and citizens should expect us to meet. Getting back to that position is going to take us some time. Let's make no bones about it. The ICS, when it comes in on the 1st of July, is going to have a job of work with its hands. But it's something we're all prioritising, and it's good to see in a number of areas, cancer rates, for instance, in many areas we are seeing things moving in the right direction. And let's not also forget that our practices never closed during COVID. Our acute providers never stopped operating on patients, but the pandemic has made it incredibly difficult. Things have moved in the wrong direction. But we do have a plan. If anyone's taken the time to read the operating plan, for instance, it does set out in there very clearly our trajectories and what we're looking to achieve over the next year or two. A lot of work to do, Tim, but yeah, we're all fully committed to moving things back in the right direction.
Thank you for that.
Thanks, Tim. I'm just going to step back to Lynn's response to Jan's question about child COVID vaccinations.
Okay, thanks, Paddy. So we manage children under probably, it's actually 3 cohorts if you class 16 to 17-year-olds, but I shall just report back on the 12 to 15 and 5 to 11 cohorts. So in terms of 12 to 15-year-olds, currently out of 49,000 cohort, 30,378 children have been vaccinated. So that equates to 62% having had the first vaccine and 39% fully vaccinated. In terms of the 5 to 11-year-olds, which we only started in Easter, we have seen lower uptake, but as I said, we've been seeing between 7 and 1,000 patients, well, children coming through a week. We're currently at 9.5% have had their first vaccine, so that's 8,200 out of a total cohort of 86,000. So I think while we're higher than the national average in terms of, well, all of the cohorts, but children as well, they are significantly lower than the other cohorts, and obviously they're significantly lower at risk as well.
Thank you very much, Lynn. That's really helpful. Thank you.
Okay, thanks, Jan.
Okay, thank you. Peter.
Thanks, Paddy, and thanks, Marcus. And I think, like Tim, you know, I'm pleased that we're in an improving position, but you know, let's not lose sight of where we've come from. And you know, long before the pandemic, we'd normalised poor performance, and whilst you're right around the 52 and 104 week waits, actually our performance against most of the other constitutional targets wasn't very good at all. The pandemic has brought a whole range of other challenges, but I think something you hinted at, it actually brought the partners together. And so I think, you know, what we see now in terms of that collaboration and that move to integrated working really has come as a consequence of the fantastic efforts that were made across the system to respond to those pandemic challenges. What I need assurance on is that that is going to continue, and that we don't get to a point at some point in the future where we revert to where we were beforehand. And, you know, those, was it toxic relationships that were referred to? And, you know, let us be very, very clear that we are where we are today because we are working together effectively, and those relationships are as positive as they are. Because if we ever lose sight of that, then there's a danger that we might go back to somewhere we don't want to get to.
Yeah, I mean, I completely agree with that. Both points. Yeah, performance against a range of constitutional standards pre-pandemic wasn't great, and it's gotten worse. I think there are some areas where we have performed well for a while. Mental health, for instance, is one area that's often a bit of a sort of often ignored, and given the impact on people's mental health the pandemic's had, it's very much come to the fore. Yeah, we are some of the best performers across the Midlands on a whole range of mental health indicators, and we do have an outstanding and a good mental health provider in Staffordshire and Stoke. But let's not kid ourselves. You know, we weren't in a great place for our targets, etc. And some of our waiting list positions pre-pandemic, and that's got worse. But you are absolutely right. The only way we're going to resolve this is by working collectively across health and care, and we cannot afford to lose the way that relationships have strengthened over the last couple of years, and go back to, you know, when that KPMG report came out and it talked about the balkanisation of Staffordshire and Stoke-on-Trent. That's not somewhere that anyone wants to go back to. And again, it will very much be around the ICS and the ICB to ensure that those relationships persist into the future. But I think we're handing that over, the role we've played in improving system relationships. I think we're handing over at least our part of that in a much better place than certainly you know, we entered the pandemic with.
Thanks, Mark. Because the reason for raising it is that, you know, we want them to nurture that into the future and not let what we've done go to waste.
Okay, thank you. Simon.
Hi, Simon Jones, a GP in East Staffordshire. Marcus, it was just a return on the comment you made about some easing of the system pressures. As a kind of frontline primary care soldier, I'm not really conscious of that happening in primary care. And system pressures often refer to the front end of A&E and waiting times in secondary care. And I think probably the GP colleagues on this meeting would probably feel that we don't want to get forgotten that we're actually very busy. Now, if waiting times for outpatient appointments are 30 weeks instead of 40 weeks, that doesn't actually ease the pressure in primary care. You know, I mean, just as way of example, my practice, which has got 6,500 patients, we were offering 22 sessions a week in 3 partners. We've now increased that by 8. So we're now offering 30 sessions a week. Now, obviously, all the partners on the call will know that we're paying for that. Now, I'm not worried about the money, but we've increased by 8 more sessions, but we're basically just keeping our heads above water. So there's been that extra work. You know, we haven't shortened the time taken to see us. We're basically keeping it like it was before, but by that extra number of appointments being offered per week. So the feeling is that the system pressures may be eased, but I'm not sure we're necessarily feeling that in primary care. That's really just a thought.
If I could just make a general comment, and then Lynn might want to come in again and just talk a bit more about what we're doing around the primary care dimension. Again, I use my language carefully. It's easy. It's not where we want it to be. And I think the urgent emergency care system, particularly over the last few months, has been under, well, it has been for some time under huge strain. The kind of areas that NHS E&I and nationally they've been looking at very much is things like, for instance, ambulance turnaround times and people waiting in the community, and what are you doing about that then? So when I say pressures are easing, I fully recognise that pressures are still there, and it's still really, really difficult for, as you put it, frontline staff. No less general practice than staff working in ED, for instance, and really, really busy ED. So he's still pressured, he's still really busy. But given where we were a few weeks ago, it does feel as if we're getting into a better place. But I'd fully recognise the comments you're making. I mean, I'm accountable to 145 practices, and we do very, very frequently get the message back from practices. Yeah, it might be better there, but what about us then? So an awful lot of work to do to ease pressures in primary care, and it is through Lynn's best efforts. There's quite a lot of work we're doing at the moment to try and make some inroads in the pressure you're under. Lynn, do you want to just pick up some of the specifics, I guess, around what we're doing to address Simon's concerns?
Yeah, sure. And I think you're right, Simon. In fact, I know you're right because I've looked at the data. So currently, compared to pre-pandemic levels in Staffordshire and Stoke-on-Trent, activity in primary care is up by 5 to 7%. We also know that compared to 5 years ago, we've got a 7.2% reduction in whole-time equivalent GPs. So it says to me that GPs and practice staff are working harder than ever to deliver more. Certainly, we've been working very closely around an access plan with general practice who've been completely on board with us, and we've seen a lot of those pressures from last year post-lockdown start to ease, and we know that people are able to get through on the phone, and they are able to have an appointment with a GP either face-to-face or by telephone, but we know that practices are under pressure. I think we know there's no more GPs out there. I think that's a given. There is a national commitment to increase primary care workforce over the next 5 years, as per the previous commitment back in 2016 that didn't necessarily pan out. So what we've got to do, I think, is work very differently in general practice. We've got the additional roles reimbursement scheme. We've appointed 342 whole-time equivalents alternative roles. So things like social prescribers, community prescribing pharmacists, advanced physios, etc. But we know that they also have a burden on GPs in terms of that additional supervision. So it's a kind of, you can't win from that perspective. What I think we need to do is really look at the model of general practice going forward and how we work. We're doing pieces of work at the moment to help alleviate things like workforce. We've appointed 2 clinical GP leads to look at recruitment and retention in Staffordshire and Stoke-on-Trent, but I do think we need to be quite radical in terms of how general practice looks going forward, how it integrates into the wider primary care services, and look at working quite differently, I think. But there's no quick fix, I don't think, Simon. And you know better than I, having faced it every day.
Simon, in terms of visibility, Marcus was talking about the Shrewd system tool to sort of give an overview of activity, particularly in the sort of urgent care pathway. The ambition with Shrewd is to add GP data in the future, and sort of the next phase of Shrewd we should be looking at a sort of GP indicator of activity. So, from a system perspective, there would be a view of what's happening in general practice as well as the wider system. I think, Anna, you had your hand up, but it's gone. But I hope we've answered your question, whatever it was going to be. Have you got a question? Nope. Can't see you.
Sorry, I don't know why. It would have been follow-up of Simon, really. First of all, the pressure in the general practice is increasing. It's not easing. I think all the GP colleagues will agree with that. The alternative roles that Lynn spoke about are helping with appointments, but they're not helping GP workload, because all these professionals are doing referrals that are coming back to the GPs to address. They're asking for for tests that they can't really interpret. All this coming back to the GP, and they need continuous supervision. So actually is increasing GP work. We're working 12 hours a day. We have increased the number of GPs we have. Funding has gone down. And I understand that there are things in the system and the indicator and the GP indicator as well as the wider system. But if you do want to have an increase in the GPs in a few years, you really need more permanent and practical steps, I believe. A lot of our, something else, already in our own practice, 2 of the young GPs are leaving for other countries that have general practice, and others are of the registrars that just finished are on the edge to see what will happen in general practice in the near future, and they're ready to go. So you may find again that the government plans for increase of the GP force could be in the same way, could lead to a reduction of the ones in 2016, unless they do something really radically different.
Okay. Lynn, I'm going to ask for a brief response, because it's a big question. You could spend all afternoon talking about it, and then we need to move on.
And I think that there's been a review released today by Dr. Claire Fuller from who's an accountable officer in the South, and she's also a GP by background, around next steps for general practice in terms of more integration, in terms of using the workforce in different ways. We're not going to manage it up these GPs, are we? And I absolutely agree with you. We need to make it attractive for newly qualified GPs coming into the system. So I've not absorbed the outputs of this review yet, but certainly it's been released today, and maybe that will start describing an approach to the future that's perhaps more sustainable.
Right. Thank you. Gary, quick question, and then we need to move on.
Quick comment. The problems that we face in general practice are not just about general practice, they're about the whole system working together for patients. We're not going to solve one part without solving. We're not going to be able to, I don't want to use the word solve and fix, because it sounds like there's a single problem that you can just do something and it will get better. It won't. We actually need to work together to actually resolve the problems and make the pathways and everything else smoother. I've had a quick look at the fuller report. It's interesting. It does talk about general practice. It doesn't talk about integrating general practice into everything else. It talks about integrating it the other way. So there's certainly some things that we need to go at with that as a system in the future. There are quite a lot of things we can do within the planned care sphere that we're already doing that will have an impact. But none of these things are quick fixes. They are transformational, and as we all know, transformation does take a little bit of time, even where you've got completely willing partners in addressing that, and there are no barriers. There are still some barriers we've got to address in order to develop the stuff that needs to come on board. But hey, that's no different to any other kind of change management, is it? So we'll just carry on.
Okay. Thank you very much for the contributions. Gary's words on integration feel like a lead into the next phase. So the financial report, Paul Brown.
Okay, thank you. Marcus has given a good intro to this, so I'll be fairly brief. So in terms of last year, the year that finished 21-22, we achieved a surplus as a collective of CCGs of about 600,000. Each of the 6 CCGs made a small surplus. We achieved our mental health investment standard in each of those CCGs, and we met our running cost targets as well. So obviously very pleased with that, and I'd add my thanks to Marcus, really to the whole to all colleagues for the work done to bring about that result. All that is subject to audit. The auditors are with us right now, working through the positions. We had a brief update from them at the audit committee that was held earlier this week, and at this stage there's no material matters to report. We're hoping it stays that way and that they'll find the accounts in order and give us the true and fair opinion that we're looking for. The audit committee will be looking at the final accounts in more detail at our meeting later in June, and then we'll be able to update the governing body thereafter. So that's the year that's finished. The year that's now underway into towards the end of month 2 of that year. A tricky situation. I mean, really the whole NHS is now looking to get back into sort of full operating mode. So really the challenges, operational challenges that we have are significant, and quite rightly so. We support them in terms of increasing the number of patients that we see in the elective pathway to start bringing down the waiting list. The continued investment into the mental health investment standard to improve mental health services, continued investment into primary care, and many other things, particularly mention virtual wards, which is a new idea which is being developed, which is a really exciting area of providing care for patients at home that will increase the capacity that we have to treat patients on the urgent care pathway. All of those things cost money, and therefore marrying money with the need to deliver all of those targets has been challenging, and we've not been able to get yet to a balanced position for 22-23. As the report sets out, and as Marcus mentioned, the current position is that as a system we have a deficit that we expect of 26.8 million in the year. We have been asked by the region to reduce it down to nil, and we're working on that. We really want to do that if we possibly can. It's challenging to do that, but you know, we started off when we first saw the allocations at an estimated gap of about 100 million, so we've come a long way from 100 million. And again, as Marcus mentioned, at 28.6 million, although it's the wrong way around, it's a deficit, it is the best, the lowest deficit in the region, and one of the lowest in the country. So we're certainly not resting on our laurels, but just in terms of context, it's important to recognise that that we are in that relatively good position, which hasn't always been the case for our system, and it's helpful to be in that place, and also not just in terms of having an acceptable number or a better number than many. Just as important, and probably more important in many ways, is that we're seen now by the regulators as a system that is joined up, and we are able to articulate our position collectively. Not all systems are able to do that. Some are still saying, well, if you want to know the number, you have to add 3 together and ask 3 different people. We don't have to do that. We're joined at the hip. We've got a clear financial model that we all work to, and working collectively for the benefit of our residents and our patients. We also, within that plan, have one of the best performances in terms of planned efficiency improvement. That comes from two sources. One big source is the work that many colleagues around this virtual table have done around the flat activity, flat cash strategy that we agreed, and that has borne fruit. And there are many examples of where it has been successful in terms of reducing the flow of patients into the acute sector, better care for patients closer to home. You particularly mentioned the work that Cheryl Hardis has led around care homes and reductions in referral from care homes into the acute sector, much better for those patients, better health outcomes, and it's saved us a lot of money. So all that's come together to create a position which we're happy that we're in a relatively good place. We're not happy that we've yet arrived at a completely balanced position, and we're continuing to work on that and see if we can get there. There will be a resubmission of the plan that's being required nationally later on in June, middle of June, 20th of June. We do expect there to be some further allocations from the centre, recognising the higher inflationary costs that the NHS is currently encountering. That will help, and we're working through whether that's enough to get us from the 28.6 down to nil. That's the year we're now in. And then finally, the sort of slightly longer term look, the position in 23, 24 and beyond. Marcus mentioned this number, so our underlying position as we calculate it, which is the position that we'd expect to get to eventually, has come down from 200 million to 133, but 133 is still clearly a substantial challenge. Recognise it reflects that a good deal of the plan that I mentioned for 22-23 is supported by non-recurrent sources of income which will disappear, so we know that we've got a long way to go. The financial strategy that we agreed here as governing body a year or so ago of flat activity, flat cash, as I said, has been effective, and we're going to continue with that approach, but build on it around the area of productivity improvement. And we recognise completely the comments that Simon and others were mentioning it previously. The system is working incredibly hard. Absolutely, that is the case. But we do know also that the NHS as a whole has received significant amounts of money as a result of the COVID situation. It hasn't yet returned to the levels of volume of patient care that we provided before the pandemic. And that's for many reasons, and they're operational reasons. They're not because people aren't working hard or anything. It's because huge numbers of staff have been off sick, because they've had to isolate. We've had the operational constraints of separating COVID patients from non-COVID patients. All those things have affected our operational productivity. But we have that opportunity then to get back to the levels of productivity that we saw before. And so, the continuation of our strategy will be, can we find ways of using that capacity that we have once staff start coming back into the workplace, that capacity increases without increasing cost? And can we find ways of increasing the number of patients that we treat through that capacity, thereby reducing the waiting times and allowing us to use the system resources to sort out the financial pressure that we have without having to go back to cut back services and take out cost at source. And that was really the basis of the strategy that we created last year. The flat activity, flat cash strategy was, let's find ways of holding capacity flat and rather than taking money out. As I said, that has started to work. We want to see that through to the next phase, and we're fully determined now as a system, having got to a position of relative stability on the finances, is to stay there and indeed to get back to a truly sustainable position with annual surpluses that we can then reinvest in our clinical services. I think that's a reasonably rapid run through, Paddy, where we are on the finances.
No, very helpful. Nice to end on a positive note in the CCG's career, because most of it has been a tale of woe. So thank you for that. Questions, Wahid?
Thank you, Chair. It's not a question, it's just a comment really. Dr. Wahid Awasi, GP and clinical lead for mental health for Staffordshire and Stoke-on-Trent CCG. Absolutely delighted, Paul, to hear that the system has made a clear commitment that moving forward we'll be meeting our requirement to invest in mental health through the mental health investment standard. So absolutely delighted really, and I know how much work has gone into this. And since this is our last meeting in public, really, I really want to thank all our colleagues, the governing body colleagues, both present and the past. Over the years, have really supported to make sure that we continue to invest in mental health. This is one of the top priorities for the CCGs. I'm absolutely delighted. I think the support I had enjoyed through these years, and we have made it possible that we are one of the best systems in Midlands and East in terms of most of our mental health targets. So absolutely delighted and thankful to all the members for this vote.
And you've played a huge part in that yourself. The fact that the Mental Health Programme Board is so joined up, isn't it? It's a collection of all the different trusts and the different system partners, and it works collectively to decide how to invest the money. That's why we've been so effective, because of that collective working. And as I said, you've played a big part in that.
Okay, David.
Thank you, Chairman. I raised this point at Finance Committee, but I'll raise it again. The forecast deficit, the planned deficit, has not been approved. So therefore, we aren't actually at break even, in my view. I think we're overspent. And in month one, we're in the order of £1 to £2 million overspent, much as that will be funded. But we're accumulating an overspend at the rate of up to £2 million a month. So at the end of quarter one, we'll be handing over, in my view, around £5 to £6 million deficit, unless this plan gets approved, and as I say, it has not been approved. That sounds like sour grapes after everything else that's been said, Paul. Sorry for that, but hand it to you.
Yeah, no, it's a statement of fact, David, and that same position exists. And I think there's one system I found out of the 42 that is a break even. 41 are not. We're one of the 41 that are not. We're one of the smallest deficits than 41 they're not, but we still have a deficit. You're quite right, and I think hopefully the report does make it clear that the forecast position, as you quite rightly said, is a forecast deficit, a deficit of 28 million as a system, 20 million of that falling into the ICB part, and you're quite right as well that in the 3 month period that the CCGs will operate, at the end of that, unless something else changes, we will have a deficit that will roll into the ICB. So you're quite right to raise it. I mean, that is been fully flagged with the incoming ICB team. They're fully aware of it. So to a region, and although they haven't approved the plan, as you say, they are completely aware of what it is, and yeah, privately, we'll recognise what we're doing. But obviously, yeah, they expect us, as is the requirement on all people, to break even.
Not least the incoming ICS CFO understands the position.
Yes, I've spoken to myself this morning, and he does.
My point being, if we are to be prudent, we should show the pessimistic position, not the optimistic. We're showing what we want to happen here, as opposed to what is reality. That's why I raised this. And being one of the better overspends, in a way, is rhetoric, because we are overspent. We cannot afford that we're doing. I go back to Paul. I apologise at the start of this because things are going well, but we are in deficit. We can't meet that deficit, and we're not illustrating it.
Well, I think we are. I think the board paper quite clearly shows the forecast outturn position of 20 million deficit. So I don't think we're saying anything different to what you're saying, David. As I said, you're right to draw attention to the fact that we're not on a break-even trajectory. We're on a deficit trajectory. That is correct.
And the forecast position says break-even against plan. That's the bit I'm picking on.
The forecast position shows a forecast deficit of 20 million. The plan is currently showing is break-even against plan, because we're planning on 28 million deficit. So what you're saying is true, but on the point of making is the board paper makes it clear that we are saying that as a system we will make a deficit unless something changes.
Okay. Thank you, Chair.
Okay. Thank you. Thank you, Paul. We'll move on to the quality report. Heather.
Thank you, Chair. I'm not going to spend a long time, so I hope to recover a few of the minutes we've lost. Just a couple of things I did want to particularly draw out. One of those is historically we've had issues with the autism service, as you know, and there is currently a reported increase in backlog in the autism service, although the provider are working exceptionally hard and working very closely with us to make sure that this is rectified. There has been significant increase in the caseload. It's up by 192%. And there are also significant people not attending for appointments. So the DNA rate is really, really high. So the provider have been appealing to families to make sure that they are notifying for any cancellations. And I thought a public board meeting is as good a place as any to reinforce that very important message. From a quality and safety point of view, in respect to that service, the provider are undertaking a weekly review of complex cases to make sure that nothing too complicated, too urgent is missed, delayed, overlooked. So we are confident in respect of quality and safety, but of course want to see those numbers improving. We've spent quite a long time today talking already about the situation with regard to ambulance delays, and of course that applies to all of our providers, although UH&M has been a particular challenge. Linked to that has been the ongoing issue around staffing, although the staffing situation in the whole area has improved significantly since the last board report. With regard to the ambulance offload delays, the provider, UH&M particularly, are doing random sample audits of around 50 patients on a regular basis. And we did have a significant and focused discussion at the Quality and Safety Committee with paying particular attention to the quality and safety of patients going through those services, but also those who are waiting in the community for ambulance transfers. We're also working very, very closely, very hard with West Midlands Ambulance Service themselves, because as we don't directly commission this service, this is commissioned by another area on our behalf. Sometimes we're not notified as early as we need to be where there has been an incident. So we've had a meeting with Mark Doherty as the Chief Nurse for West Midlands Ambulance Service, and making arrangements to make sure that we're notified swiftly as and when serious incidents occur in respect of any ambulance delays, so that we can, as soon as possible, as early as possible, identify what's gone wrong, why it's gone wrong, and hopefully work with the providers and with the ambulance service on making any improvements that are needed. A couple of other things I just wanted to pick out. Combined healthcare, you'll see within the report that there has been a noted increase in suspected suicides, although review of those hasn't identified any themes or trends. But as we always do with suicides and potential apparent suicides, we are watching closely, and there is a suicide prevention group that meets and that continues to meet. And there are other members of that group on this call who may want to contribute to any wider discussion around that. Independent hospitals have been a challenge for the last couple of years for us, as I think most people will know. We've had a couple of closures. We continue to work with those who remain. We're working particularly closely with the Woodhouse at the moment, and are expecting further work in respect to the Woodhouse over the coming weeks and months. Again, just a reminder that from a Staffordshire and Stoke-on-Trent point of view, we avoid, we don't actively place in there very often. We've got one patient placed there at the moment, but as the host commissioner, i.e. on our patch, we have responsibility to make sure that patients are safe, that any notifications of patient safety concerns are acted upon, and we do that on a regular basis. Something that's in the report that I do want to pick up that is a good news story. We've had some challenges, as I've just said, around learning disabilities, but one of the really good news stories as we come to the end of CCGs is in relation to the review of learning disability deaths. As you know, we have to review every death that happens, and whilst we'd rather none were happening, it's right that we are reviewing them. And from we call it leader, so from a leader point of view, it is good news. We've been commended on our approach. We're top in the region in terms of performance and in the top 5% in the country for leader reviews. So really, really good news story. And then just a couple of quick other lines. One, just to acknowledge the fact that hot off the press today, obviously there is the report into the two recent and very tragic deaths, Arthur and Star, and some strong recommendations in relation to the system approach to managing those kind of cases going forward and managing the safeguarding agenda going forward. We're already statutory partners with the local authority and with the police and work very closely through the boards. And through those Safeguarding Children's boards, we'll be, I'm sure, in the next meetings, going through the recommendations and working out our strategy locally to make sure that we do everything we can to avoid any such incidents on our patch. And then my final point really was I'm in the fortunate position, a bit like Paul really, that I am going into the ICS, and I just wanted really to give my commitment to the board, particularly based on some of the questions, that I'll continue to push for assurance and improvements in relation to quality, and we'll do everything in our power to carry the learning forward. Other than that, I'm happy to take any questions.
Thank you, Heather. Can I bring you back to ambulances? I think this week Mark Doherty was quoted in the Health Service Journal and then in national press speculating about the potential for West Midlands Ambulance to collapse somewhere in the summer because of pressures, and but also highlighting the significant, very significant increase in incidents. I think with quadrupling, I think was the figure quoted. And at the same week, we've had was it Northwest Ambulance services who've been well, there's an investigation going on as to whether they have been fully cooperating with coroners and others around incident reporting. So are you assured that we are getting the data through around incidents with West Midlands Ambulance about our patients, and that you're happy with what you're getting, and that we have oversight on the incidents that are being created by the current circumstances?
Partly would be the answer to that question, Paddy. I think the honest answer is, because, as I said before, we're not the lead commissioner, sometimes there can be a delay in us being notified of those incidents. And clearly, if we're really going to learn from those incidents, we need to know as early as we possibly can. Now, when Steve and I met with Mark Doherty a couple of weeks ago, and that was the meeting I referred to, one of the requests I put into Mark was that we find a way of giving us early notification. So sometimes it can be a matter of weeks before we hear about an incident happening on our patch. So we are working now with Mark on getting that process set up so that we get early notification. And I suppose linked to that, at the moment, there's some root cause analysis backlog, and I think Mark wouldn't mind me saying that. So investigations need to be undertaken to find out what went wrong in each of those cases. And what we've also done is offered to Mark some support with undertaking those root cause analysis investigations, using some of the expertise that we've got within our team. We've got people who are trained in root cause analysis, myself included, but to support him to make sure that we're as aware as we can be and alert as we can be to incidents that are happening on our patch. So I think the short answer is partly, but there is a complex background to that.
Thank you. I mean, lead provider arrangements always create a difficulty, but don't take away our responsibility to ensure that our patients have safe care. Jan. You with us, Jan?
The buttons won't work. Thank you for the report. I just wanted to say I attended a nursing home quality assurance meeting the other day, and was very impressed with the report that was provided on Leader in terms of the investigations, or perhaps not investigations, but evaluations that take place on individual patients. And I was very reassured about the in-depth nature of that reporting, and very impressed really with the quality of the information. And I've suggested perhaps that example could come into quality and safety, as it did feel to me providing information that probably is missing in the report is the depth of understanding that's achieved from the evaluations of each of the deaths. So I was really impressed and felt that was excellent. The other thing I wanted to raise was in relation to Arthur and Star. I know it's going to be one of my last opportunities, but can I say, Heather, could you take forward that within child protection, health visitors, I'm sorry, do occupy a very important role. And I'd be most grateful if you could take that forward. If they're going to have teams of social workers, police, health visitors probably ought to be the key component that takes part in that team. So could you take that forward, please?
Yeah, I'll pass that message on, Jan, and just to acknowledge really your positive comments about Leader. than to say I will pass those on to the team. So thank you for that. But I'll pick up that issue around health visitors. Thank you.
Can I apologise, Paddy, because each time I talk, I forget to say who I am. I probably don't know who I am. I'm Jan Topless. I'm lay member for Cannock Chase CCG.
Thank you. You don't need to repeat that now. That's good. Thank you. Thanks, Heather. Performance report. Jane. Jane, I believe this is your penultimate day in the CCG. So
it is. So go out with a bang. Is this it?
I know. Whimper would be
3
fine.
reports in one meeting.
Thank you.
Okay, so this is the performance report, the first one. So I'm going to concentrate on where we were. I'll use the work on we've done on the operating plan to sort of talk about what we're trying to get to. I think it's fair to say from the performance reports that it continued to be challenging for March and into April. We saw significant pressures on all parts of the system: primary care, urgent care, and elective care, and our community colleagues and our social care colleagues. All of which meant that performance was challenging during March and continues to be challenging to April. Is now improving. However, we did continue to make some progress, particularly on elective care. We have seen the progress being made on the 104 weights. What we are doing is monitoring that, though, because we know that there's going to be real challenges getting that down to 0 by the end of June. Elective care saw the most pressures, both in terms of weights in held ambulances, weights in A&E, and challenges of flow within the hospital. I think that was acknowledged as being a huge amount of work, both of which Marcus and Paul have referred to, so I'm not going to go into any detail about that, to both understand and to be able to, going forward, actually make significant changes and improvement to how that urgent care is delivered. Cancer, what we have continued to see demand and people coming into the system, into the cancer pathways. We have seen some challenges around the 60-day pathway. Quite a lot of that is driven by some of the challenges we also have in some of those diagnostic pathways, and that is acknowledged. Again, there's been progress has been made on starting to improve that performance, even though we are just coming out of what have been probably some of the most challenging months ever, not just for us as a system, but across the NHS in terms of maintaining performance. So the rest is in the paper, Chair, so I'm not planning to reiterate it again.
Thank you. Any questions for Jane? Oh, thank you very much. ICS update, Sally.
Hello everybody, and Chair, apologies for being late. I had to do my Freedom to Speak Up Guardian training for the new role in the ICS, but I'll pop some slides up and provide an update, which you should all be able to see now.
Yeah, see that.
Yeah, okay, thank you. So, right, so I just wanted to sort of set up who's actually on the board and been appointed so far. I think this slide has been seen at a meeting in public, but these are the new non-exec directors working to Prem Singh. Right, sorry about that. Yeah, these are the board roles that have been appointed to working to Peter Axon. As you can see, Paul Brown and Heather Johnston and myself have been appointed into roles, along with Paul Edmondson Jones, who people will know from working for the City of Stoke-on-Trent Council. Alex Brett is the Chief People Officer, Chris Ibel is the Chief Digital Officer, and there are 2 additional roles here that are being interviewed for on June the 1st. We've seen this slide before. This is the compact that's been agreed about the way we're going to behave as a leadership group, so I'm not going to dwell on that one. And these are the vision, priorities and purpose for the ICS, and those very important 4 priorities there for us to see, as well as the centre of the triangle about improving outcomes for population health, tackling inequalities, enhancing productivity and value for money, and then helping the NHS support broader social and economic development. Last Friday, it's only Friday last week, we had to submit a whole raft of documentation. It's kept my team very busy getting through all of this. We've had initial feedback from NHS England, who are very pleased with what we've submitted. We've had a few minor tweaks to make to the Constitution, which Paul Winter will talk to you about shortly. And this is the timeline here for the ICS in terms of what we've got to do to get the ICB established. So tomorrow we've got a checkpoint. This is a submission I talked about last Friday. Tomorrow Peter Axon and I've got a checkpoint with NHS England to talk through where we're at and what they consider any issues are. 1st of June, the AO has to write to the ICB Chief Exec regarding the due diligence, and we've got a paper on here about that process and how that's going. There's a further checkpoint with Prem Singh on the 8th of June and Dale Bywater to go through anything else that's outstanding. And then a joint statement of readiness letter will be sent to NHS England. We should receive the establishment order from the national team for the 30th of June, and at midnight on the 30th of June the CCGs will be abolished, and on the 1st of July the ICBs will be established. So we do have to develop a memorandum of understanding. We've got one already that covers us up till the end of this first quarter of the year. The new one really is quite a key document because it's about setting up those delegations, about how we're going to work with system partners as well. So that was my summary for this. I'm very happy to take any questions from people on it.
Any questions for Sally? No questions?
Thank you.
All very clear.
Thank you.
Thank you. We will move on. We're still a wee bit behind. So first of the items for approval and discussion is the paper on withdrawal of commissioning policy, which is about consultant to consultant referrals. Mark.
Afternoon all. Thank you very much. I'm Mark Seaton. I'm the Managing Director of the CCGs in the North. For board members, governing body members, I'll assume the paper is read. For members of the public, you'll have heard earlier about the due diligence work that's going on in terms of transferring policies to the ICB from the end of June, beginning of July. As part of that work, we've identified a policy that's largely redundant, and that's the consultant to consultant policy. As with all policies come to governing body for approval, it's only appropriate that this one comes to governing body for approval to withdraw it. So that's really why it's here. So largely the policy relates to what we used to pay for, but because the payment mechanism is now changed, as I say, the result of that is the policy is redundant, and therefore we are proposing that it be withdrawn. So the rest of it's in the paper, so I'll take that as read, Paddy. So I'll just be happy to take any questions.
Any questions for Mark? Asif?
Hi, thank you. It's Asif Ahmed, Brood GP, governing body member, various other bits and pieces. Just want to be clear. I mean, I get this is about the costing of funding and payment by activity / results mechanisms, but just want to be reassured that this is not potentially going to be misconstrued in secondary care as a green light to be bouncing things back to general practice primary care, to be referring to their colleagues down the corridor if there's further advice needed, because that's slightly one of the issues with being seen by one consultant, then being sent back to see the GP to get the opinion for the person down the road, down the corridor, when actually we're referring the patient for a concern that needs answering.
Absolutely. I say there's no change in the way we expect providers to behave. This is essentially a commissioning policy that set out what we would and wouldn't pay for, which is largely redundant, and therefore it's been withdrawn. Now that we're in block contracts, for want of a better phrase, where there is a fixed income for the provider, it's largely in their interest to manage this better. And therefore the commissioning policy is probably not necessary. Doesn't mean to say it's any less valid. It's just the emphasis of where the responsibility lies for it has changed.
I would probably say that I think that even with the policy in place, we probably still had things sent back. But I just want to, I mean, if we could just make sure that the hospital teams are aware that they do not. This does not mean they need now to send people back to be re-referred. But yeah. That's fine.
Yeah, that's fine.
Okay. Gary, did you want to comment?
So yeah, Gary, I'm Chair Cannock Chase CCG. I'm also Plan Care Clinical Lead for the system, at least at the moment. Asif, in terms of what happens around consultant referrals, we will be picking that up at a system level, because we probably need an equitable way of managing it across the county rather than necessarily individual trust. But Mark's right. Individual trusts will need to manage this, and how they do that, we probably need to come up with some ways of doing it. Having said that, has it been a successful policy? Well, given that more of our referrals into secondary care outpatients are not from general practice than they are from GPs, I have to say I'm not sure it's the most successful policy ever, but there you go. But happy to see the back of it.
Okay. Seeking approval for this paper. Silence is assent. Approved. Thanks, Mark.
Thank you.
Jane, operational plan.
So as already been to alluded, we have now completed a final version of the operational plan to the required deadline. That included both a narrative submission setting out how we intended to meet key priorities and targets set out in the NHS operational guidance, and as well as a technical submission that set out our trajectories for what we intended to deliver in terms of workforce, urgent and elective care. I'm not going to go into huge detail. The plan is there to say that it was developed completely collaboratively with different organisations and individuals in those organisations taking responsibility for leading and bringing together, that we collectively triangulated all the information, so that it was done at both organisational and system level, so that there was a shared understanding and shared agreement that the position that we were reached was understood and owned by all, and that the figures added up against that triangulation against workforce, against activity, and against finance. And thanks to all the colleagues across organisations in the system, our finance and our workforce colleagues and our analysts, who all worked incredibly hard to make sure that all this information came together into a coherent document. And last, my thanks to my head of planning, Vicky Inch, who pulled everybody together and pulled the final report together to make sure that we had a coherent operational plan that went in. In terms of the key messages from that, and we have had the feedback now, As Paula said, our finance position looks to be one of the best in region, though we are still rated red because they are still looking for a break-even position. In terms of urgent care, I would say that to summarise the feedback is the plans look good. Their concerns is that there's some significant ambition that's required to actually deliver what we say we are going to deliver. Elective, and I have to say this is a system approach, so this is not all about UH&M. We will meet the 104-week wait, so we will have, and across none of our providers on current projections, anybody waiting 104 weeks at the end of June. We are not in so good a position in terms of the increasing the level of activity over and above where we were of 1920 to enable us to bring the backlog down and get back to the position pre-pandemic. The challenge we were set, and I'm not going to go into the technicalities, was to a sort of gross position of 110% above 1920 activity and net 104%. RWT of our three major providers will probably hit the target. Both UHDB and UH&M are struggling more, and in fact UHDB is slightly worse in its position on this than UH&M. And that does mean that we are only just above the 100% on those figures that went in. On cancer, we are now predicting that we will, across all our major providers, hit those targets. And probably on the final element, that they are on health inequalities, we've shown that we've got plans to deliver, but we are being challenged on making sure that we are making those more smart targeted, so that it's clear both the time and the extent to which we will deliver changes on that core 20% of most deprived and the 5 priority areas. Having had the feedback for our post plan, and I think this is probably a real reflection of the challenges for the NHS, we're now being asked to resubmit. We're expecting very much it's going to be an iterative process across the year, where we're going to continue have to update our plans to show progress. And to be fair, all our providers coming out of what was a difficult couple of months in February and March are really starting to look again at how they can drive further change. And we are seeing improvements in the position, for example, on elective against the trajectories that our providers have set. So we're now being asked to resubmit again on the 20th of June a further plan, which against the urgent elective cancer and health inequalities position. We're also being asked for weekly progress reports so they can see how we're our workings to get to that resubmission. But I think we're in a reasonable place. What we are also doing, and Paul Brown may also want to say more about this, the NHS operating guidance had 10 areas that they wanted us to focus, of which only 4 they asked us to report on in the operating plan back to NHSEI. There is a piece of work that again is being led collectively across the system, and in this case is being led by Steve Grange from MPFT, which is starting to pull together how all those priorities and the targets within those priorities are being taken forward as a system, so that we have a collective understanding of what we need to deliver across this year, and that will also be turned into a public-facing document that sets out what we are trying to deliver across this year as an ICB. So, Chair, that's a summary of the progress to date on the operating plan.
Thank you. Quick skate through a big document. Any questions for Jane? Whilst we're waiting for any questions, I'll maybe make a comment. And I read the workforce part of the operating plan with interest, because it seems to be probably one of our biggest risks, and we can talk about productivity and elective recovery, but always going to be very tricky without the people to do it. So when you're looking at 10 or 11% vacancy rate across the trust and 10% turnover and 5% sickness, there's a big hole in in workforce. So I guess what monitoring of this is going to go on, and at what point will people take a judgment as to whether those plans are being realised and whether they might need to find other solutions in the absence of workforce if that's not fulfilled?
So I think they're almost being continuously monitored, Paddy, as we are, because of the challenges we are keeping reviewing and looking at that data. To be fair, our workforce was marked best in class. It's got green. We are the only system that got green for workforce. And it was deemed to be both realistic and significantly ambitious, and understood the restraints and had clear plans for dealing with some of those restraints around recruitments, etc. But we absolutely acknowledge in the plan, and we acknowledge as a system, that it is one of our big challenges, workforce. We cannot magic up a workforce given the training times, and actually some of our biggest challenges are in particular areas of skill, and that's why we're seeing some of the challenges around some of the areas of diagnostics such as ultrasound, because of the lack of supply, shall we say, in those particular skill sets. So I think we absolutely acknowledge, and that's one of the reasons why, as part of the thinking, it's got to not just be about a traditional model, because some of the restraints on workforce and capacity are not going to go away. And so it's trying to think creatively, and that's why NHSE are so keen on things like the virtual ward, why some of the work we've done and the kudos we've got for the investment we've put in social care to stabilise the care market, etc., is being seen as important, because it's that recognition that the future is not just about doing more of what we did in the past.
Good, thank you. Can't see any more hands up, so thank you very much.
Thank you.
You're on again in a moment. So ICB Constitution, Paul or Sally, or is it a double act?
It's me first, but just to say that we had to submit as one of those documents the ICB Constitution. Paul has spent many hours working through the Constitution and actually talking to people about what's in it through the governance network, through the Chief Exec Forum. We were informed yesterday that there were only a couple of very minor amends for that Constitution. It's been resubmitted, and really I would ask the governing body to note all the hard work Paul has put into doing this on our behalf. And it is the ICB Constitution. It is for a unitary board, not for a membership board like the CCGs have been. But I'll hand over to Paul now.
Paul?
Okay, yeah. I've got a couple of slides, Paddy, if you want me to share them, or do you want me to just read out what's changed?
Pictures are good. Stick a picture up.
Okay, just bear with me whilst I just remember how to do this. Hopefully people can see something that looks like a slide with ICS update written on it.
It's all black at the moment.
Okay. Is it still?
Yeah.
I seem to have frozen as well completely.
Wind back and forget I said a slide was good and just crack on. That's not.
I can't do anything at the moment other than everything's completely frozen.
Oh, there it's showing. It's showing.
Okay, apologies. Techno difficulties. So yeah, as Sally said, just a quick run through of just a bit of the background. We covered some of this at the confidential session in April, where one of the requirements of the Health Act is that the CCGs propose the first constitution of the ICB, which we duly did. We did say at that point it was still subject to a couple of minor changes that have since come out. So those have now been notified to us now that the bill has had royal assent and is an act of parliament. So if I just move on. So basically, very quickly, it's just it's a tidy up version. So it looks clean. So there aren't lots of different coloured text showing what changed when. It looks like a proper document. We've added the new ICB logo, which is one of the 2 points Sally referred to that was fed back yesterday from NHS England. We've simplified a couple of sections where we were quite lengthy with our descriptions. We thought it was helpful to the reader, but NHSE said you can do that through other means. So that's primarily the background and forward, where we've done quite a lot of what is an ICB and what does it do, which there'll be dedicated web pages on our future website that will explain all of that. And then the governance handbook, which is another new feature of the different direction that ICBs are taking, again, will be a detailed section on the website where a lot of the contents that were formerly required in CCG constitutions are now stripped out of the model constitution. Saves about 100 pages, but that 100 pages is still required somewhere, so we put it on the website, or we will put it on the website. So we've just simplified that list. Rather than describing what the document was, we've just said what the document is and where it can be found. We were also asked by NHSE to be specific down to borough council level as to what councils the ICB area covered. So we've done that for the 8 on our patch. We've clarified the chair's term of office to start from when Prem Singh was made the designate ICB chair, and then to run from there on. There's a minor change to the trust, NHS Trust and Foundation Trust partner member selection process, which is all about the forward plan obligations. This is a statutory duty for them. A couple of changes to the national provider selection regime, which is basically the procurement regime, which those who have paid attention to all of the white paper stuff over the last 12 months knows that the procurement regime is potentially changing quite significantly. So we put a couple of mandatory phrases in there that, and then the supporting notes, which was a lot of the detailed clarification as to why something was in the Constitution or not in the Constitution, as the case may be, is now inserted as an appendix. So that should help the readers when it eventually becomes available. Now, NHSE have had it. We understand their intention is to put all of the 43, 42, however many ICBs there are nationally, on the NHS England webpage that's dedicated to ICBs, which may be as early as the 1st of June, which will be slightly in advance of the availability of the ICB's public-facing website. But if NHSE want to do that as part of the establishment, that's what they want to do. So if they don't do that, it will be on the ICB's website effective as of the 1st of July.
Thank you. From the CCG's governing body perspective, is there anything that we are required to do in terms of the ICB constitution? As you say, we've proposed it, but presumably there's no further action for the governing bodies.
No, we asked that when it was proposed, and I mean, proposed is the euphemism for approved, isn't it? Signed off in April. We said it was going to be pending a few changes. None of those changes are material, so there isn't really a requirement to go back and ask for approval again of something that was last month.
Yeah. Okay. So no further action required. And that's for information. Tim, question.
Yep. Thanks, Paul. Just a quick question. I'm aware that obviously each ICB will be able to develop its own local arrangements. I'm just thinking in terms of patient engagement and consultation, is there any expectation that the Constitution needs to feature any detail about that, or is it really at a high level in terms of principles?
There is a section that is about how an ICB will demonstrate its transparency and its accountability to its public, which covers the statutory requirement to engage and consult, etc., the public. It's pretty high level, but it sets out a number of, it sets out sort of like the 10 national principles on good engagement. It covers a bit of the kind of, you know, what the statutory duty is, and then it will signpost to the detail on the ICB website where the comms engagement strategy, or whatever it's, people and community strategy, whatever it's called in the future, will be posted, and it'll explain that the entire substructure of how, you know, locality sort of groups feed into ICB groups, and the VCSE, the voluntary sector, etc., all play into the big picture. So it's really a very high level signposting facility only in the constitution.
Yeah, all right. Well, thanks for the update. I've just given that this is the last meeting of the CCGs in public, I just wanted to raise that up, because I think clearly the future communication and engagement at a local level is going to be important.
Absolutely. Yep.
Thanks.
Okay, thank you, Sally and Paul. And then the next item is, Sally, progress on due diligence.
Yeah, I'll just put some slides up. Right, okay. Right, you should be able to see those now. So, I'm going the wrong way when I'm driving. So the CCGs put in place a very robust approach to their due diligence. We had a huge checklist of information that was required by NHS England. We involved John Howard as chair of the audit committees, but we've also involved our internal auditors in doing a review of each of the main subject areas for the due diligence. John has put in place a review in detail in phase 1 of each of those subject areas with internal audit, and then in May we've had 2 additional extraordinary audit committees to get updates on where each of those work programmes have got to, which have landed well. We've been joined by Julie Holder, who is one of the new NEDs and will be the NED for the audit committee for the ICB as well for that. Now, the next part of the process is obviously we've brought it to governing bodies today so that you are aware of the robustness of what we've gone through, and I will ask John Howard and Marcus to speak about that process too. But Marcus's role then is to write to the ICB chief exec to advise that the CCGs have followed a due process to prepare for close down for the safe transfer of staff and property. And that's the timeline here that we've been through to do that. That includes all those extraordinary audit committees that we've had, and I think we have done this extremely thoroughly. But can I ask either Marcus or John, I don't know which one wants to come in first, to comment, please?
John.
Oops, sorry, just correcting a telephone going in the background there. Thanks, Sally. Yes, a good, robust process. The 6 areas, for those of you who are perhaps not familiar with the constituent parts of the checklist, were finance, commissioning, including contracts, quality, strategic planning, including business intelligence, primary care and human resources. And as Sally indicated, the first pass was to take them individually, discreetly, and to have internal audit do some checking in terms of the robustness of the due diligence process they'd undertaken. Whereas the second pass was taking them in 2 groups of 3. And once we'd concluded that work, and with your agreement, Chair, I'll read the recommendation that came from Extraordinary Audit Committee to governing body. It hasn't reached you formally as yet, but I'll share it with you now. And it's a recommendation from the Extraordinary Audit Committee to the governing body in respect to the 6 areas that I've just listed. That in respect to each of the 6 areas, we are assured that good levels of due diligence have taken place in readiness for the formal handover of duties and responsibilities, to the ICS-ICB. Furthermore, we would like to place on record our appreciation to all staff involved for the work undertaken as part of the process, which has been very much appreciated at this busy time of the year. So a very strong recommendation to our governing body in terms of the level of due diligence that's been achieved. We didn't want to single out anyone in particular, but as part of Sally's team, I think the person who's been orchestrating behind the scenes is someone called Kirsten. And she does deserve a mention. A lot of other people have been involved and deserve our thanks and appreciation. But the one I would have gone to and said, "Oi, why is it not working? Why is it lumpy?" You know, she was held responsible for bringing it all together. So I think it's important that we record our thanks for the orchestration behind the scenes and the smooth running of the due diligence process. Thank you, Paddy.
Thank you. Marcus, do you want to comment?
Yeah, no, thanks, Paddy. Just echo John's comments. Huge thank you to everyone that's got us into this place. It's been a huge piece of work, and I don't want to repeat what I said in the in my accountable officer's report earlier, but I'm just conscious that Sally wasn't here for that. So a huge thank you to Sally, to Kirsten, to Paul Winter, to the whole team, really, in terms of the work they've done to get us to this place. Really robust process, and as I said earlier, me writing to Peter to say I'm assured about what I'm handing over, and also giving that assurance to governing bodies. Probably that letter will be one of the easier letters I write. So really robust process, and thank you, Sally, for all the work you've done on that, as well as Kirsten, Paul Winter, Nikki Hartness, and everyone else. And also, as I said before, I'll say it again, thanks to John for the chairing the Extraordinary Audit Committee. He's made what was a really difficult process as smooth and as supportive as possible, whilst obviously needing to be assured that what he's being presented with was going to do the job we needed it to. So thank you.
Sally, any more on the process?
No, I don't think there's any more to say on this one. It's just if there's any questions from anybody, and of course if anybody wants to find out more about the detail involved, we can supply it in spades to you.
And is there any requirement for the governing body to receive this report, or are we just taking it from the Extraordinary Audit Committee? Is there any requirement for us to sign off the due diligence process?
So we're bringing it here for you to note the process that's been involved. The duty is with Marcus to complete. There's a template letter he has to complete to send off to Peter with the information in it.
Okay, John.
Thank you, Paddy. What I should have also mentioned was that our meetings were fully documented and minuted, so there is a robust audit trail for all the meetings of the audit committee in extraordinary form.
And I should just add, Paddy, that the slides I've shared today about the ICS and the due diligence, and Paul's slides about the Constitution, we'll ask Jill Hackett to send out and put on the website so people can access those reports, because we just didn't have a chance this week to get them done on time.
Okay, thank you. Does that complete what you need to do, Sally?
Thank you very much, yes, Chair.
It does. Okay, thank you. Okay, we will move on to item 19, which is items for ratification, and it's the recommendations from the Finance and Performance Committee. Paul.
Yes, thank you. The Finance and Performance Committee met on Tuesday at a very full agenda, as you've seen in the pack. Just two things where there was a recommendation or a decision made by the committee that needs ratification here. The first of those was a discussion on some options for investment into lower GI 2-week referral hub, which after considerable discussion was supported. And then the second was a continuation of the debate we had a bit earlier when I presented the financial position around the changes to the budget, noting the points that David made earlier around the fact we don't have approval for the deficit budget, but with that caveat, we asked the committee to approve some changes to the budget reflected in the later allocations that we received. Both of those two recommendations were agreed by the committee. Can I just bring in David as chair just to say a few words?
Thank you, Chairman. Thank you, Paul. Yes, I agree with Paul's abbreviation there. We're happy with both of those recommendations. I'm happy with them both, as for the committee. Thank you.
Okay, thank you both. Any questions before I seek ratification of both of those proposals? No. Okay, seeking ratification. Any dissent? No, they're both ratified. Thank you, Paul. And then item 20, recommendations from quality and safety. Heather.
Yeah, thank you. This will be a short and sweet report. It is a nil report, but we did it for good practice reasons. So just to be clear, no recommendations requiring ratification this month. Thank you, Chair.
Thank you. Do I need to ask for questions for the nil report? I don't think I probably do, actually. Okay, items for information. Jane, COVID-19 update.
So it still remains with us, but I think we have a position where things are calming down considerably. So from in March, when we were a position that 1 in 16 of the population were infected with COVID on the ONS survey data, we're now about 1 in 45 to 1 to 49. Of course, that data is 2 weeks out of date because it's retrospective data, so we're probably even better position. That is also now reflected in the what's happening within our hospitals in terms of people who are occupying beds who have COVID positive. At the current position is that over 2/3 of those are admitted to hospital for other reasons but have COVID. So we're not seeing the same level of people who are being admitted because of complications of COVID. But we're still seeing around 100 beds occupied in UH&M, smaller numbers in both RWT and UHDB. At the height, nearly 25% of the beds within UH&M were occupied by people with COVID. So that starts to help understand why the system was under such pressure in March and February because of the numbers of people in beds with COVID and the implications of that. We're expecting to see the numbers continue to decline. The thought is it's probably now a more gradual decline than we've seen in other waves of this, partly because of the level of reinfection that we are seeing with the Omicron variant and the speed at which people can become reinfected. So we've moved from a position where with some of the early, you were probably about 6 months before you became at risk. We're now somewhere just over a month where people are becoming reinfected in some cases. So it has changed that picture in terms of the infection, reinfection. But that's basically the position where we are, Paddy.
Okay. Any questions for Jane? Peter.
Yeah, thanks, Paddy, and thanks, Jane. I just wonder, what confidence can we have in these figures, bearing in mind that pretty much no one's testing themselves now, and even the government advises to, you know, if you do test positive, just to isolate for 5 days and then carry on with your business. So I'm not sure how confident we can be in the statistics, bearing in mind the raw data is perhaps not as forthcoming as it once was.
And that's why what I've given you is the figures not based on the testing figures. I've used the ONS survey, which is probably the most accurate. It's a survey method. They're continuing to do that survey, so they're continuing to sample the population on a random basis. So it's extrapolated from that survey, but it is probably because the testing data is because basically national testing's now ceased. The ONS data and linked to the bed, so we know those are linked with the level of COVID and the admissions. So the fact that both ONS and the bed admissions are coming, bed occupancy and admissions is coming down, all back up that though we've continually got quite significant circulating levels of COVID in the community, the position is improving.
Okay, thanks for that.
No more questions, Jen. I think that's your final report for the CCGs. You leave us on Friday, don't you?
I do indeed, and it is my final report.
Best wishes in your new role in the future. Will you be talking about COVID in your new world, or is that your last discussion of COVID?
I don't know. I suspect I won't get away from it, but my role is slightly different in this. My new, I'm majoring more on my public health background around equalities and innovation. So
thank you for your role for the CCGs. Thank you from the CCG governing body, and particularly in the last 2 years in coordinating and helping our system steer its way through the pandemic. Thank you very much.
Thank you.
Move on to the update from subcommittee chairs. Peter, I think you're going to do the report, not report, but feedback.
Yeah, in Anne's absence, I'll take the report as read, Paddy, and any questions I'll pass on to Sally.
Right, quick pass there. Any questions for Peter to pass on? No, I don't think there's any questions. Thank you. Primary Care Committee, Jan, I think you're also standing in.
I don't think I've really got any comments beyond the report.
No, that's fine.
Thank you.
Audit, John.
Yes, thanks, Paddy. Just 3 quick points that have been touched on during the course of this meeting. One is to confirm that we now have the final Head of Internal Audit opinion, which is very positive. We've shared this with you in draft form at the last meeting. It's where we would want to be. In old money terms, it's a grade B. That's where we would want to be, and it's based on robust evidence in terms of the internal audit plan work that was concluded in respect to last year. And of course, we're in Q1 now of the new year, and I can confirm that work is progressing well as we move towards the ICS in terms of the elements of the internal audit plan in Q1 for the new year. Second point, I think Paul already touched upon this. The external audit is auditing our final or our draft accounts. It's proceeding well. There are some technical issues, but I'm assured that they should be sorted out in due course, and we are on schedule in terms of the timescales required to be submitted by. And the third point we've just touched upon really, and that is to confirm formally to the governing body that we, in extraordinary form, we did complete our due diligence review, and in respect to all areas, we are able to confirm good levels of assurance were achieved. Just additional to that, Paddy, if I may, Julie Holder and myself, as the outgoing and incoming chairs of audit, continue to work closely together regarding the transition.
Thank you for the summary. Any questions for John? Nope. Thank you very much. And John, I think you're still on Remuneration Committee.
Nothing to report.
Nothing to report. That's in a couple of weeks' time, I think, isn't it?
Yes.
Right. Thank you. Sally, item 23, rapid decision-making process. Anything to report under that?
No, nothing to report either, Chair.
Okay. Any other business? I've not received any notification of any other business yet. Steve.
Yeah, it just seemed I didn't realise this was our last public meeting, and it just seems I want to take the opportunity really to thank our exec colleagues for all the help they've given us and given me over the time we've been in a CCG. I particularly want to highlight Marcus, because I've known Marcus the longest, I think, of all our exec leads. But they've been tremendous leaders, and they've been hugely resilient, and they've been there when the clinicians have needed them. And I just wanted to take the opportunity to say thank you, and for wherever you end up, I will always remember that working with all of you over time.
Thanks for those words, Steve, and I certainly second them. Really, it's been a great team to work with.
Yeah, thanks, Steve. And I said my piece at the beginning. I don't know if anyone else wants to make any comments, but thank you for that. Much appreciated, Steve. Thank you.
Thank you, Steve. You've been a diamond, by the way, Steve.
Yes, because obviously you're in the same position as well, aren't you, Steve? So it's we're all in this together.
But so you and I and others have been through multiple iterations of redesign. But you're in the trenches together with your managerial colleagues and the whole team. With my clinical directors. I find it very hard that dissolution and the breaking up. It's almost like a bereavement for me, we've all been working together very closely for a number of years, and then we're not, and I find it quite poignant, quite sad.
No, thanks, Steve. I do agree.
I absolutely agree with Steve on everything he said, but I think we also need to mark out our lay members for all the help they've given us over the years. They've gone above and beyond. They've consistently worked far more hours than they're actually meant to do, and our secondary care consultant Doug Robertson as well, and our chairs. So it does feel like a bereavement, because certainly I've been working on the CCGs. I was adding it up 12 years now. That's been my time, and most of the faces I'm looking at have been involved for a similar amount of time too. So we wish everybody well.
Alison?
Yeah, it just really to say thank you for Steve for sort of for thanking everybody, which I think is really on behalf of all of us, Steve. So thank you very much. And again, I would just say, yeah, my CCG journey started when Marcus was at North Staffs, and so I've sort of gone all the way through with Marcus as we've managed to join with Stoke and then join with the other CCGs working in common. And I think we should all be really proud of where we've got to. So again, I think we should, I think we should be all be proud of where we've got to and what we're handing over. So yeah, thank you to everybody.
Thanks, Alison.
Okay. Any more comments? No. Meeting effectiveness, I think it's been a very effective meeting, and if anybody thinks otherwise, send us a letter in July. Can I bring us to questions from the public? Ian.
I think you would expect me to say something, Chairman.
I would absolutely hope you would say something.
Something nice, Ian. Yeah, before you get into the other stuff.
Reiterate my thanks. I'll miss crossing swords with you, Marcus. I've known you since the PCT days. And quite a challenge, but it's kept my feet on the ground and stimulated the brain cells. I've known Steve Fawcett from primary care group days, so we go back way back. And
I'm only still 21, Ian. You remember that, yeah?
Yeah, I do. And meetings in Tunstall and such. And I know you all work really hard. Okay, I'm a critical friend, but I know how hard you've all worked and served the public. And frankly, what you've been through over the last couple of years serving the public is even praiseworthy isn't enough. So thank you all. Thank you all very, very much. Right, I'll get to the blunt stuff where I'll start annoying people now. These are the questions. Right, I am concentrating on ambulance handover delays. I attended West Midland Ambulance yet again yesterday, and they are, to say the least, they're alarmed. I know you said they're improving, but Royal Stoke is still by far the worst for ambulance handover delays in the West Midlands by a considerable amount. I was somewhat astonished when Heather mentioned about lead CCGs, etc., because as you will remember, Chair, when you, Dr. Hannigan, were last Chair, I did bring up ambulance handover delays in September the 30th, 2021. And I followed those up several times since at the governing body. And I've followed them up several times since with UHM and also with West Midlands Ambulance. The first thing I'm going to deal with is quality and safety. Obviously, it affects the CCGs because CCGs have statutory duties with regard to quality and safety and monitoring. In July 2021, please bear with me on all my questions. In July 2021, a Stoke resident bled out in the community because ambulances could not respond timely due to handover delays at Royal Stoke. A Regulation 28 report, Prevention of Future Deaths, was issued by the coroner, the Stoke coroner, in November 2021 to both NHSE, who oversee, I understand, the CCGs, and to UHM. Since the issuing of the Prevention of Future Deaths report, ambulance handover delays have continued to dramatically increase at Royal Stoke. Why have statutory bodies in this instance seemingly taken such a cavalier attitude towards a Regulation 28 report issued by Her Majesty's Coroner to protect the general public? That's my first question.
Ian, we'll take one by one. So, Cheryl, do you want to start and perhaps then Heather follow on, or Steve?
I mean, I can start with a general overview about the ambulance handovers, but I think Ian's question was about a specific section 28. So I don't mind which way we go.
The Regulation 28 report. That's about that specific one, which I would have expected any commissioner to take due regard of and to take very seriously.
I'll start off. I think one of the bits, Ian, is we haven't had the Section 28 letter. I've talked to Heather. We haven't seen something. We're not the lead commission, so it may have gone directly to them rather than to us. But your point about ambulance delays is well made, because although you highlighted that ambulance delay, we know there have been other incidents of harm from ambulance delays, which and particularly in the period between February and the beginning of May. We as a group, as a system, we have been working ferociously hard. There's been also a laser-like focus on trying to relieve the ambulance service of their challenges, and the predominant issue was flow through the hospital. It was the inability to clear spaces in the ED to allow the ambulance services to go to unload their patients. Now, I can give you a long list of the actions that we took as a system and as providers to try and get control of the situation. And in fact, in the last 10 days, the situation is vastly improved. I can put data up to illustrate that, but I wouldn't want to gloss over the challenges that we had during those 3 months. We had huge staffing problems, particularly in the community, which then played out into delayed in getting people out of hospital beds and therefore delay getting people through the hospital. I don't know if Heather wants to add anything else.
I put my hand up instead of taking my microphone off mute. Apologies. So yeah, just to reinforce the message that Steve's just given. So in terms of that particular regulation 28, I don't think we've had sight of that. I have checked and triple checked, but I will go away again and ask the team. So I'm confident that we haven't, because we have a process, Ian, as I'm sure you'd expect. So if we get a regulation 28 as the CCG, we have the same amount of time as any provider would, any other organisation would, to respond to the coroner. And from a governance point of view, that's kept really, really tight. So we're chased by our governance team if we haven't responded in the right timeframes. And I'm particularly confident that I'd know if we'd seen this one, because obviously with the media interest in the case that happened in Telford, we would have probably gone back to the, well, not probably, we would certainly have gone back to the file to have a look to see if there were any common features in those cases, to see if there's any more learning that we need to implement. So I don't think we've seen it, and I will go away and do a final triple check. And if I do find anything different, Ian, I'll contact you directly and just let you know. But I think just in terms of process, I don't think there has been a cavalier attitude, certainly from our point of view, because if we'd had it, we would have acted on it and we would have responded to it.
If I can quickly come back on that, what is alarming, therefore, is an individual died. There's a Regulation 28 report that goes to a provider, and NHS England and the commissioning body, which is you, I know you've got lead commissioners, haven't had sight of that Regulation 28 report. That of itself is alarming. Why didn't UH&M inform you as well? Because you have CQRMs with UH&M. There are different bodies who should have kept you in the loop, and they haven't. That of itself is alarming. So that needs looking at, surely.
Yeah, Ian, let me just respond to that. So first of all, I just want to be really clear. As far as I'm aware, we haven't had it. I'm not making any suggestion that anybody's kept it from us. You're right, we do have CQRMs and we do pick up Regulation 28. It is in the contract and we are required to be notified, so they are logged. I need to go away and just do a final check from those CQRM minutes that we haven't had it and it's not just passed me by in terms of the content, but I think I'd know. So I'm not making any allegations against any other provider at this stage or any other party. We just need to go away and check, and I will come back to you as soon as I know the answer.
Okay, I can send it to you, obviously. Right, the second one is harm reviews in the quality report, and it's again ambulance handover delays. You talk about 50 random patients, January 2022, and you were looking at any harm. That's less than 4% of the individuals who were delayed over an hour. It's over 1,200 at Royal Stoke. And you were discussing that on the 6th of May. What are the results of that review discussed on the 6th of May, especially for one heart attack, where we know that door-to-needle time started to get extended, stroke, where timely intervention is imperative, fractured neck of femur, again, where timely intervention is necessary, And further, are there any harm reviews? You said there have been, but are there any harm reviews instigated as to the impact of ambulance response delays to community 999 needs? Because yesterday, West Midlands Ambulance said that was by far the greatest risk. It was even a greater risk than being held outside hospital.
Again, thanks, Ian. Really good questions, really. And actually, I think I anticipated the part about the incidents in relation to community delays, because I went away and checked ahead of the governing body just to be clear on numbers. So although the numbers have been high, and I'm not making any excuses for anything, there have been 12 serious incidents reported since January in relation to delays in the community. Each of those serious incidents is currently subject to root cause analysis. And as I think I said earlier, we are working with West Midlands Ambulance on how we can get all of the RCAs done as quickly as possible so we get maximum learning. In terms of the harm process, I also anticipated the question that you were going to ask around the meeting on the 6th, and obviously getting to know you well after all these years, and to the team. Now, I've been corrected, and the process, the meeting on the 6th of May was about process, not about doing those reviews. So we actually don't know the outcome of those harm review meetings yet. However, initial reviews suggest no harm at all. But I'm going to add to that and just reinforce a message that I've been giving for some time now. We are doing a piece of work at the moment with our patient safety specialists. And when I say we, I'm talking as we as a system, as in a collective system. All of the patient safety specialists are working together on improving the definition of harm so that when we say no harm has occurred, we're not just looking at the things that would be obvious harm, but we're looking at some of the less obvious harms as well. So that piece of work is happening, and those patient safety specialists and that harm review piece will pick up all of the work around the any apparent harms as a result of ambulance delays. So that's happening in the background. And again, if you want me to spend some time just talking through that a little bit, or maybe come along to our patient safety specialist group and have a conversation about how we might feed that through, then I'm happy to have that conversation.
That's brilliant. Thank you very much for that. Just a quick clarification on that. 12 SIs, it's our community, is it? We're talking about Staffordshire and Stoke-on-Trent.
12 serious incidents reported by West Midlands Ambulance between January and now relating to delays transferring patients into hospitals. 12.
In our patch?
In our patch, in the whole of the geography, yeah.
Thank you very much for that clarification. And the last one, and I'm sure this is the one that Cheryl knows is going to ask. Right, I asked on March the 31st for the trajectory plan for the whole care system, the date of enactment for for addressing ambulance handover delays and trying to nullify that. I still haven't received that. When am I going to receive it? Please, pretty please.
Do you want me to come back on that one now then, Ian?
If possible, no, a part of it. Just say I'm going to receive it and I'll send you an email, blah, blah, blah. That's all I need.
Okay, so you've had something today, Ian, which was attached to the email about the set of actions that the system had put together as a way of responding to the ambulance handovers. I think alongside that, though, Ian, there's a wider plan that's about pre-hospital, in-hospital and post-hospital. Of course. That's the bit I think that you might be referring to that I haven't sent you. Oh, okay. And I'm happy to send it to you. So it's finally been ratified, if you like, with the system. So I'm happy to send that to you. I can send that to you. It'll probably be tomorrow now, Ian.
Well, whenever, Cheryl. Right, thank you very much. And I hope you have a little party and you buy better plonk and you do better for food than Chris and such than Boris did at his parties. Good luck to you all. Thank you very much for all you've done.
Thank you, Ian.
Thank you.
Okay, end of questions. I just can't see any more members of the public, so just close the meeting. The next, that was the final governing body meeting held in public. We have a final closed governing body meeting on Thursday, the 30th of June. Sally, do you just want to say something around the ICB meetings? Are they held in public, or is there an intention to hold them in public?
No, they will be held in public. They'll be it's very much the same model that we're using as CCGs. So 6 meetings held in public a year, and then the meeting alternate months. The meeting in between will be a closed meeting and a development session. So
okay, so a similar format.
Okay. Yeah.
Right, I'm going to close the meeting. For governing body members. It's now 10 to 4. We were due to start the confidential at 4:50.